Welcome and thank you for joining us for today's Mastermind session, Quality Improvement in Diabetes in General Practice. My name is Sydney Cruikshank and I'm from the PHN Education team. Today I'm joined by my colleagues Deborah Walgansky, who is a Primary Care Improvement Officer with the PHN, as well as Emily Parsons, who has just joined me on the Education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For me on the Central Coast, that is Darkinjung land, and I'd also like to pay respect to elders past, present, and emerging. Now, a few things to let you know about today's session. It will be recorded and available for you to view in our education library in a couple days' time. I have uploaded the PDF attachment of today's PowerPoint session in the Handouts tab, so if you want to download that and take it away with you today, please feel free to do so. As attendees, your camera and microphone are automatically disabled. However, if you have any questions throughout the presentation, please just pop them in the question box located within your control panel, and we'll answer those at the end of the session. An evaluation will also come to you directly after that session today. Your feedback is extremely important to us as it enables us to provide future education. So we really appreciate you filling that in. Now I'll hand it over to Deborah for today's session.
Oh, thanks so much, Sydney. So yes, welcome to Quality Improvement in Diabetes. I'm a Primary Care Improvement Officer at the PHN. Today it's a little bit busy and a bit detailed, but if you can get at least 3 things out of today, that would be excellent. We're going to go over data sources. So I'm going to show you 2 reports that might be useful in your practice. Then we're going to go on to some quality improvement activity cycles, and then lastly the clinical information system navigation. Most of this content is available on our website under programs, and then under the primary care support, and then under the diabetes tile. So that's the red box there in the bottom right corner. Okay, so first off, a really great way of doing quality improvement is to participate in the Diabetes Alliance Plus program. So this is a case conferencing model that runs in your practice with the Hunter New England LHD and the PHN. Basically, it's a chronic disease management program where the patient has continuity of care and their practice, but it's multidisciplinary, and so you'll be visited by the endocrinologist and the diabetes educator. And I think the diabetes educator is actually online with us today, and also the program manager. So welcome Sharon and welcome Morag. And also there's great benefits there for CPD points. And there's just a couple of photos there of a clinic that we ran in Canada. The EOI, their expression of interest for the Diabetes Alliance clinics, is on our website, again under programs and then Diabetes Alliance. But you can also get that from your Primary Care Improvement Officer. And there's a lovely little YouTube video that explains it a bit more. Just to get you to save the date, 17 November for 3 days, we're running the Diabetes Alliance conference called Ensuring Equitable Access to Diabetes Care. So that's in the Hunter Valley. So that'd be great if you could attend that. Okay, so most of this content is taken from the RACGP guideline for management of type 2 diabetes in general practice. And it basically evidence-based practices about the diabetes cycle of care. Even though the MBS item numbers have ceased and the service incentive payment was replaced by the quality improvement payment, this evidence-based clinical practice still exists. So in your clinical operating system, so medical director and best practice, you can access the diabetes register. And so this is a list of all patients with diabetes in your practice. And this is a great way of keeping on top of that cycle of care each year. So medical director and best practice, basically the register is accessed from the front screen. There's lots of nice navigation tabs that you can do there that have got some value added reports. So medical director in particular, it is a bit busy, but the diabetes assessment will take you across at least 6 tabs of history, examination, ophthalmology, food care, investigations, and medication review. So that's a nice way of keeping that up to date by adding missing values and dates of service. The best practice diabetes cycle of care is very similar. Basically, you want to attend those 14 items every year and have your diabetes register populated with your work so that you know what each patient, what their status is with the cycle of care. So another great way of looking at your practice cycles of care is through your CAT4 tool that the PHN provides the license for you. So there is a report. Unfortunately, it's still called Diabetes SIP Items, but I'm pleased to report yesterday I talked with PennCS and they've agreed to change the title of that report to Diabetes Cycle of Care. Just that the SIP term was a bit misleading because that's not in operation anymore. However, these reports will be kept. So basically, this one shows you the items recorded within the practice. And you can see this practice is particularly good at recording smoking, but particularly not good at recording foot exam. So that's a nice way of seeing what your strengths and opportunities are in your practice. The other report that's under that tab is called Items Completed per Patient. And this is a nice way of seeing how you're going across your patient cohort. So the recommendation is you start at the right-hand side of the 14 items. For example, here you would work on the 24 patients that have 11 items completed, and those 24 patients just need 3 more items to do. It's just a bit more efficient that way than starting at the left-hand side where you've got 0 or 1 or 2 items completed. So in your practice, you'd be able to click on these bar graphs and re-identify your patients. So at the PHN and at the LHD, we're not able to see patient names in these reports. That's something that's limited to within your practice. Those reports are populated by where you actually record the items. So this is the mapping diagram of CAT4, and you can see most things are recorded in the diabetes cycle of care screens. Obviously, the pathology will drop in through the HL7 results, but just to draw your attention, the foot exam and the eye exam, where those are recorded, so those tend to be not so well done as we saw on that other screen. And also smoking and medication reviews. They're recorded in medication reviews and alcohol and smoking history. For example, that's for best practice, but medical director will be quite similar. So that's important that you code it in the right spot so that the audit tool is able to read it. So the PHN, we have made 4 quarters of quality improvement activities. These are available on that on our website under that diabetes tile, and basically it's as per the patient journey. So patients that are indicated with diabetes but are not yet diagnosed, then quarter 2, for example, you might work on chronic disease management, getting a GP management plan and team care arrangements. And then you might have a look at the diabetes register, as we discussed, and see how you're traveling with getting those patients complete. And then each year you would end up having a cycle of care completed as per the guidebook. So this here is the Diabetes Alliance report. And so what would happen with the endocrinologist and the diabetes educator is you'd agree at those clinics to work on a couple of activities. For example, screening and diagnosis of diabetes, identifying women of childbearing age, and recording of BMI and waist circumference, and then you could tick them off as being complete. So that's a nice opportunity. This here is our Plan, Do, Study, Act form, and we've just filled this in as an example. Basically, you would use those reports and get your baseline figures, and then make an agreement to reevaluate that. So you would come up with a few ideas. They're like commencing nurse-led diabetes clinics, doing training and foot checks, maybe keeping that diabetes register up to date, and perhaps checking with allied podiatry and your correspondence in, to get these foot checks up to date. So the plan, do, study, act cycle is basically making a very detailed plan. As you can see there, it's quite specific. And then you would review the plan to see if you actually did execute it, and then study the results with a subsequent report and see that you did improve or not, and then you would act. So you would continue the activity, or you might tweak it a little bit to make it more meaningful. So that's a nice template that we have available on our website. And this type of documentation is very useful for you to keep for your accreditation activities, and also for your quarterly quality improvement PIPs. Yes, so that's also the Diabetes Alliance report. And this is our general practice summary. So the PHN also produce a quarterly report. It's a bit more generic than the specific diabetes one, but nonetheless, it will provide you with some baseline data. So for example, this is about the cycle of care. This will show you at the beginning 7 of the 14 items, and it will show you your progress over a period of time, how you're going with that percentage of monitoring. And then in the general practice summary report, we also provide some data, and that's compared to other practices in the PHN and then also across Australia in the grey. So you can see this practice has got 73% HbA1c recorded, which might look good, but it still means that there's 25% not recorded. And likewise, the blood pressure and diabetes, this particular practice has got about half recorded and about half not recorded. So there's always opportunities for quality improvement activities. So ethnicity is something that's reported in the diabetes report. And you can see this particular practice has got Aboriginal patients with diabetes of about 11%, which is much better than all other practices, which is at 6%. And likewise, the general practice report, we will put in there where you have ethnicity not recorded. And so that's an opportunity, for example, in this practice to find the 157 persons who don't have their ethnicity recorded. And that's really important because it means then that you can find patients to perform the Indigenous Health Assessment, the 715 item number. And that's really important because during the 715 assessment is where we end up finding the chronic disease such as diabetes. For the smoking status, the diabetes report will break that down into different cohorts. Importantly, it does show the nothing recorded for smoking, and also the PHN report will show you the not recorded cohort, and then benchmark that across all PHN practices and across Australia. So that's a nice activity to do. BMI is also shown here. It's got the not recorded portion of the practice patients, and then the PHN report can also show you this quite large number of this particular practice. It's got 1,800 patients. Not that these are with type 2 diabetes, but nonetheless, it looks like an activity that could be done. And then if we look across Australia, you can see it's not very well done anyway, but this particular practice has got 40% recorded and there's 60% left to go. So that could be a nice quarterly activity. With waist circumference, tends to be about 50% achieved, but we know that central adiposity is a risk factor for cardiovascular disease. So an idea is maybe just consider doing a practice blitz of every patient every time for a period of time. And that's a nice way to get that measure increasing. So with the HbA1c, the diabetes report does break that down into cohorts of control and not controlled, and also not recorded. And our PHN dashboard does show that percent as well. This particular practice looks to be on par, but again, noting there's about 70% recorded and 25% not recorded. So perhaps one hot tip is maybe consider prescribing after the HbA1c is attended. So with blood pressure recording, you can see here this practice has got some not recorded on both reports. And just to realize that, as we talked about earlier, the mapping of that, the blood pressure does need to be recorded in the observation field and not just free typed in the progress notes. So that's a nice way of getting that number to increase. So with cholesterol, similarly, you can see this practice has got about 80% recorded and a bit to go. This particular measure is about the cardiovascular disease risk information being in the file, whereas the diabetes report that you'd get through the Alliance is much more specific about type 2 diabetes patients and their cholesterol. So an idea might be to put cholesterol requests in your diabetes pathology favorites so that it's always collected if required in the timeframes. So with the chronic disease management, both reports do give you a percentage of usage of GP management plans, team care arrangements, GP management plan reviews, and then also the nurse monitoring in between more structured reviews, so the 10997. And you can see this particular practice on the left increased markedly from January 2021 to January 2022. They had a huge increase of usage. And then our PHN report also will show you in a more general sense across your whole cohort. So I guess it's important, if you're doing the care for diabetes, then it makes sense to maximize your billings and consider your practice nurse, your Aboriginal health workers, Aboriginal health practitioners in maintaining the diabetes cycle of care. And so one of the final ones I wanted to show you was in the PHN dashboard. We do have a report that talks about indicated with diabetes, but not yet having a coded diagnosis. And so in this particular practice, you can see there's 469 patients coded with diabetes, and yet there's 261 who are indicated to have diabetes, but they haven't received a coded diagnosis. And just to remember that in the accreditation standards, coding is actually required, and also in the eHealth practice incentive payment, it's one of the requirements to meet that incentive. And so it's important that diagnoses are not pre-typed. They really need to be picked from drop-down list. And that's because medical director and best practice, they both use the national medical vocabularies that are approved. So in CAT4, there's a fantastic tool under data cleansing called Indicated Diabetes with No Diagnosis. And this will show you all your patient names that have anti-diabetic medication charted, or they have a HbA1c that's not controlled, or they have a fasting blood glucose. And so it will tell you in a traffic light sort of report, the red persons are likely to have diabetes, the yellow is possible, and then beige is for review. And so this report allows you to double click on the patient name and go straight into their record in medical director and best practice so that you can look at the file and clinically review it. Noting that, sometimes persons are on medicines for other reasons, say polycystic ovary syndrome, or also maybe their blood glucose is high, but perhaps that's just because they're on a steroid. So it does need you to clinically review it. But this is an opportunity to clean up these patient files and reassess and code them with diabetes. There's also the opportunity to confirm that the condition does not exist, and then you could save and remove these patients from this list, noting that anytime new pathology drops in, then they would reappear on the list. And it's also possible to find the reviewed report if you wanted to go back and see who had been reviewed already. So that's a nice little tool in CAT4. Your PCIO could help you to set that up. There just needs to be a couple of settings made with top bar. That's the PenCS tool that allows this to write back to the record. And also the clinical system that you're using, best practice or MD, etc. It needs to be open in the background so that when you're double clicking on the patient name, it actually opens their record. But yeah, your PCIO would be able to help you to utilize this tool. So just to recap what we went over today, so we've looked at some data sources. So the Diabetes Alliance program managing type 2 diabetes summary report, and you can obtain that by participating in the Diabetes Alliance program. We also looked at the PHN general practice summary, a little bit more general, but nonetheless very useful for quality improvement activities. Then we looked at some quality improvement activities and the plan, do, study, act cycle. We've got that template available. And then we looked at some CAT4 tools that allow you to re-identify patients. And then finally, we went over the diabetes register and the cycle of care assessments in medical director and best practice. So I think that's it from me, but here's some photos of another Alliance visit that we did in Narrabri. On this slide here, you can see Morag's contact details, your PCIO's contact, and also myself if you needed any further information. Okay.
Thanks for that, Deb. That was wonderful. Now, we have not had any questions come through today, so if you do have any, please feel free to pop them in the chat box. And if there are none, we will end the session today and we will post it online by the end of the week with all of the information that you've already shared. And yes, if you can fill in the evaluation for us, that would be wonderful. Thanks for your time today.
Thanks, Sydney.
Have a good day, guys.
Thanks, bye.